Okay, welcome to the Duke Spine Institute's live stream, and our patient is here with a herniated disc at L4-5, and as well as she has facet joint pain in the thoracic spine. So we're going to fix her lumbar disc herniation at L4-5 with the Duke laser disc repair. We're going to fix the thoracic facet pain with the Duke plasma rhizotomy later on. First thing I need to do is gain access to the L4-5. I'm a little bit higher than I should be, so I'm going to move south. Num. And Jordan, okay. Yeah, I was going to say your table is too high, right? That's just numbing medicine. Don't move around. You got to have Berndes fix that before I get here, okay? Shot? All right. So we're going to get started by first placing what's called the spinal needle into the L4-5 disc space. Shot? You can see from the x-ray we're just behind the facet joints. Shot? Heading right towards that disc. Nice thing is her spine is quite posterior. Let me see, shot. Her spine is actually nice. It's not too anterior as far as I can tell so far. Shot. You're doing great. Don't move. Shot. You're doing fantastic. Everything's okay. There's the herniation. I can feel it. So I could see the tip of the needle, guys and gals? Yep, right there. That is touching the herniation. I can feel it bouncing like a trampoline. So there's the herniation Jordan just showed you. It's not common to be able to see the herniation on x-ray. Let's show them the sacrum, the sacral bone. Good. And just above the sacral bone is the L5, then the L4. And the disc between the 4 and the 5 is the L4-5 disc. And that is, everybody agree we're doing L4-5 right side? And that's where we are. Let's get an AP view to verify. Are you comfortable? Lay still. We're going to put you to sleep soon, but I need to ask you a few questions. Yeah. So, wow, that herniation is way out there. Interesting. We seem to be a bit more lateral than I would normally want. Lay still, you're fine. I'm going to try to get a little more medial, just to make sure. Shot. I want to be as medial as I can. Shot. If you're too lateral on your approach, you'll end up too anterior. And what I'm doing is I'm actually using the bevel of the needle to drive my approach to be a little bit more medial every time I make a pass until I can hit her facets. You're doing great. Just lay still. The nice thing is she really has relatively normal facet joints. Huh? I mean, look at the foramen, how wide it is. It's huge. Yeah, nice. There it is. Shot. So I'm a little bit more medial than I was before. Let's go AP. So I really wasn't happy with where I was on the front back view. I felt like I was too lateral. I needed to be a little more medial. Medial is toward the midline. There you go. See the difference? Look where show them on that view there, Henry and Jordan. Show the show the pedicle of 4. Pedicle of 4. See the circle? Don't just do that. Show a circle. Yeah. See the circle?
Yes,
a bone. All right. Now show the circle of bone at 5. Bigger pedicle. And then show a line between the middle of the pedicle, like on a clock, the middle of the clock face. There you go. And notice how the needle is right there where it's supposed to be. So that's perfect. Are you comfy? Shot? Yeah. Are you comfortable? You're okay. You're doing great. All right. So this lady presented to us at Duke Spine Institute with two types of pain. One was thoracic pain, which you can see was up here. And she's interesting because when I saw her in clinic, or before I saw her in clinic, she had an MRI that showed a herniated disc up here in this area. And we were supposed to operate on this disc up here, but she had no pain up there. I said, listen, the surgery up here won't help you. So yes, you got a herniation there, but it's not causing any symptoms. And that's exactly why we don't do surgery based on MRIs. Okay? We don't do surgery based on MRIs because MRIs don't tell us where pain comes from. Patients tell us where pain comes from. When I asked her, where's your pain? Well, she showed me. But she doesn't have a herniation there. So I deduced that she must have facet joint pain. We did a facet block, what's called a medial branch block, yesterday, and she had 100% relief of that pain, which means it's not coming from a disc, it's coming from the facets, which is why we're doing the Duke plasma rhizotomy. But she also complained about pain in her lower back. Are you awake? And at L4-5, she has a herniated disc. It's just a small one, but it's right where her pain is. You comfortable? All right. No pain? How bad is that on a scale of 1 to 10? All right. Is that where you get your pain? You see, it was your disc that was causing your pain. So she has 10 out of, it's 10 out of 10, it's concordant. So you guys see her almost come off the table there, Henry? I know it's hard for you guys to see it, but if you're in the operating room, she went, ah, suddenly, because I didn't tell her I was injecting. And that's part of the test is you don't want to let the patient know when you're going to inject the dye. So she's got a painful disc at L4-5, and she was wondering, you know, this morning, is it really my disc or is it my facets? And I said, you got to trust me, it's your disc. I've been doing this for a long time. So, yeah. Bladder stimulator?
No, maybe it's
Shot? All right. Let's go ahead and show our audience why do people get a painful disc when they have an annular tear? What makes it so painful?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back. You now know why do herniated disc cause back pain. It's the annular tear, nucleus pulposus stuck in there causing inflammation. All right, Jordan, show us on the lateral view where the disc is supposed to be, right there. And look where the tip of the dilator is, folks, right there. I'm literally bouncing against the herniation. I can feel it. So I'm going to now push the herniation back into the disc through the tear that's already there. And then we're going to take it out. Is that her or my nurse? Sean?
Just adjusting everything. All my nerves.
All right, so we are now inside that painful disc. She doesn't like it. We've gone through the annular tear, which is the source of her pain.
Keep your head still, sweetheart. Head still.
You're doing great. Shot. What do you think? A little more?
Yeah.
Oh, that's good. You're doing great. Lay still. So some people move reflexively, but we are now inside that bad disc that's been causing her so much pain. Now we're going to go in there and use the laser to clean it up and repair it. All right, let's show the audience how the laser actually works while we get her a little bit deeper.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
And welcome back. You now understand why do discs herniations actually cause back pain. It's the tear in the back of the disc, and that's what we're here to clean up, that tear. That's all we're going to do, is literally clean the tear. Remove the herniation from inside of it, get rid of the granulation tissue, inflammatory tissue, and in that process of cleaning that tear, we call it an annular debridement, the back pain will go away. It's like removing a thorn from somebody's skin. If you keep the thorn in there, it's still going to hurt, right? Because that thorn is causing inflammation. There's the tear. There's a piece of the herniation right there. See the pink stuff on it? Inflammatory tissue. This piece right here happens to be a bit of an older piece of herniation because it's, look at it, how scarred up it is, collagenized, right? We've talked about that many times. The older the piece of herniation, the more scar tissue you're going to see. By the way, the laser fiber is 1 millimeter wide. So that gives you an idea of the scale of what we're dealing with inside here. Everything is very small.
We have a question.
Uh-huh.
This comes from Tino on YouTube.
Hi, Tino.
They ask, so how did this patient present in clinic? Only local pain?
Yeah, that's correct, Tino. This patient presented with only back pain, no leg pain, no weakness, numbness, tingling, no radiculopathy, 0 leg symptoms. So to most doctors, they would just tell her, go take pills, do physical therapy, try some shots, do some marijuana, but don't come for surgery because you don't need surgery. In reality, the only way to fix her back pain is surgery, the kind of surgery we're doing right now. But most doctors don't know that. They don't know how to fix people's back pain. So she is purely back pain at L4-5. Everything okay, Doc? We got 5 minutes. We'll be done with this disc. Let's have a grabber. The herniation is stuck. This is that piece that was sticking out in the foramen. Now, probably the reason she's not had any leg symptoms, if you look at her x-ray, she has a really big foramen. So there's lots of room in there for the nerve root. So even though there's some narrowing happening from this herniation, pushing on into the foramen, it's not big enough to push on the nerve root. So that's probably why she had no radiculopathy. She just has a big hole where the nerve comes out. She was born with a very big foramen, which is a good thing to have, by the way. But so the problem with her with the herniation wasn't pinching of the nerve like many people have. The problem was just the back pain. But because it was just back pain, she was ignored by the system and just told to deal with it, you know, live with it, go try physical therapy, which never works for this. She was just given pain medication, pretty much ignored. I call ignored. Of course, people will talk to you, but they don't do anything to fix you. When, of course, we can fix it. She just went to the wrong doctors. So she actually presented with two problems, since you're asking. She presented with thoracic pain and lumbar pain, lower back pain and mid back pain. And what really brought her here was her thoracic pain. And once we figured out that her thoracic pain was not coming from the herniation at T4-5 that she had, once we figured that out, we then realized the pain was coming from the facet joint instead. We did a diagnostic block to confirm that yesterday. And sure enough, the diagnostic medial branch block of the facet joints took her thoracic pain away, meaning it was facet pain and not disc pain. So once we knew that, we changed the plan. And instead of doing thoracic Duke laser disc repair, we decided to do a thoracic rhizotomy. Okay? By the way, this is really cool. You see this white thing right here? That is normal nucleus pulposus. Normal. Everyone wants to know, what does it look like? That's what it looks like. And the reason I know it's normal is it's not staining blue. I got rid of the blue stuff, and this is normal nucleus pulposus. Everyone thinks it's a liquid. It's not a liquid. It's a solid. It's fibrous. Okay? It's fibrogelatinous. What's going on? Are we on? We got irrigation? We're good? All right, we're just about done. 1 minute. And then we're going to move on to the thoracic Duke plasma rhizotomy. You can see these fibers here that I'm lasering. Those are the posterior ligament, posterior longitudinal ligament. Just below it is the last of the herniation, perhaps the most painful part of the herniation. This is the outer annulus. So this is where most of the nerve fibers are. Great stuff. So she didn't have a really bad disc. Her disc is, for the most part, very well preserved structurally. You can see the annular fibers right there. You see them? So we're going to go just underneath them and clean out as much of that herniation as I can. Questions?
No current questions.
Amazing, huh? She's going to go home in an hour. And that pain she's had for how many years? 3 years of back pain. Really bad. 3 years, that pain's going to be gone. Right after she wakes up. How do I know? Because I've done it in thousands of patients, folks. That's how I know. I know for a fact it's going to be gone. Now people ask me all the time, when you take the herniation out, you get 100%. No. The best we've ever done is probably 90%. Those are pieces of herniation, by the way, that I just took out of there. You guys saw those little blue things? Those were, each one of them was a herniation. They were small ones, but they were stuck in there, and I had to get them out. All right, looking good. I think we're just about done. 1 minute. There's the last of the tear. I don't see any more herniation. Let's take a look at the nerve root. I'm leaving the rest of the disc alone. We're not taking the disc out, we just took the herniation out. Let's see if we can see the nerve root. No, it's kind of right there. Oh, there it is. You see it, the white thing? That's it right there at the top. Okay, that's the nerve root. And we're done. Let me see, wait. Let me just see this right here. This is a little bit of herniation there, the blue stuff, tiny, tiny, tiny bit. Looking good. All right. That was nice. And that's going to take care of that disc pain for the rest of her life, as long as she doesn't re-injure it. Most people don't re-injure their disc. They follow my instructions, and they don't do things that could re-injure their disc. But you can see the disc, the nucleus is not jelly, it's not water, it's thick, but it can come out and re-herniate quite easily. So she could split out another piece of that if she's not careful. If she tries to lift something too heavy, if she tries to do too much too soon. Here you go. Lay still, we're done. She don't like it. That is for sure. There we go. All right, relax, you're fine.
Keep your head down, okay, for me?
We need you to lay still, sweetie.
Yeah, we're almost done. But you gotta stay still for us, all right? Like we talked about?
I'll hold pressure, you break everything down. All right, so we're gonna bring the scope back in to do the thoracic Duke plasma rhizotomy. So what's going on with her arms right now?
She's moving them uncontrollably with tape. We taped them 4 times.
What I would recommend is just hold the wrist
That's what we're doing. Yeah, we're doing.
up here so she can't get on her elbows and moving her torso around.
She's very strong.
Oh, I'm sure she is, but I bet you're stronger. All right. You guys want to see this? There it is. Can you see that, Henry?
Yes, we can.
That's a tiny, tiny incision. Let's see if I could show you just how small it is. All right. It's around 8 millimeters. All right. So I'm just holding pressure just to make sure there's no bleeding, which there is none, by the way. And now I'm going to numb up her skin further up because we're going to do her the Duke plasma rhizotomy. Okay, so moving from one procedure to the next, and let's get a localizer. Let's see the ribs. I'm going to be counting up from T12. And shot. All right, good. So let's widen the plates. We can see T12 is the first rib down there. I need to zoom out a little bit. So 12, 11, 10, 9, 8. It looks like I'm going for 7 there, doesn't it? Shot. Okay, folks. So scoot up a little with your fluoro north. What a beautiful spine. A little more north. Just a smidgen. All right, we know that that's the rib at T12 at the bottom. So let's count. Let's see. Shot. 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 And shot. All right, so the tip of my probe is right next to the pedicle of 12. And then we've got 11, 10. Go to the pedicle, You got to count by pedicles. 12, 11, 10, 9, 8, 7. So we want to do 7, 8, 8, 9. Everyone agree? So my needle tip is actually in the perfect position already, but let's see. I need to go a little bit deeper. There it is. All right, so the needle tip is literally in the most, show the inflection. Look at this little, there it is. You see that right there where the arrow is, folks? Run that needle, run the arrow along the transverse process, superior margin. There it is. So come medial, and then right there, you can see it goes up to the superior facet. So right at that valley where the needle tip is, just above the needle tip, that's exactly where we want to be. Jordan, can you bring the fluoro to the ceiling a little bit so you can give us a little more working room here? That should magnify a little more. I've got that. You go ahead and get the knife. So I'm going to make my first incision, 3 millimeters. The Duke plasma rhizotomy, unlike a radiofrequency ablation, does require an incision. We have to make an incision. Now I got to find that spot. Shot. And I use my X-ray machine to do that. Shot. Shot. All right, we're close, but no cigar. Very close, but I need to be perfect. So I'm getting caught up on the fascia, which happens quite often. I don't think it's the skin, right? It's the fascia that's doing it?
Yeah, I mean, you're
Huh?
Yeah, I believe it's the fascia.
Let's have the knife again. So I had to make a 3 millimeter incision, and now I have to get down to the spine to right where I need to make that burn, right where the transverse process. It's a little overexposed. Shot. A little more superior, right there. Shot. A little more lateral, right there. Shot. That's too superior. It's almost perfect. Shot. That's pretty damn close to perfection. That's right where that bad nerve is, the pain nerve. She's not liking that. And I'm going to make several burns. Shot. And that's really what we're doing, is we're just burning. We're burning a area along the spine, right where that pain nerve runs. Shot. And you have to fidget around a little bit. There we go. That's probably a little better right there. I can actually feel the mammillary process. She is contracting a bit. Let's see if I can't. And since we don't want to have to bring her back to do a repeat here, obviously, we want to make sure we get that whole area where that nerve could be. Shot. 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 does that look like the TP there? The TP looks lower, right? But how could it be there? On the other side, it's lower. Look at it. See it? No? Yeah, right there. So put your star in the middle of the TP on the other side, right? Other side. There, right? So it's like at the bottom of the pedicle. This is too high. But I'm not, there we go. That might be it right there. Shot. That looks pretty good. That feels good too. Shot. Shot. That's the problem, is I'm sliding up and down on top of and below the TP. You see that? Shot? That's like right where it should be. But every time I try to burn, she moves.
I tried taking her deeper and she was completely out.
Shot. Oh, that should be it. Let's see where this is here. Shot. Shot. I'd like to feel the superior facet. Shot. Shot. That should do it. One down. It was a bit difficult because of her anatomy. Her anatomy is such that shot that she is sort of pushing my probe away from where it's supposed to be. That looks perfect right there. Gave her a lot of numbing medicine on that one. Let's see if that makes it better. Shot. All right, so I'm going to do a second rhizotomy burn through the same incision. And then I'm going to have to make another one a little bit lower. And for those of you who are not aware, rhizotomy is really a burn. You're really burning a nerve. That's really what you're trying to do. There's a pain nerve that runs right in that spot. It's called the medial branch of the dorsal ramus. Right where the tip is there. And that nerve carries all the pain signals from the facet joint up to the brain. And if you can just get that nerve deadened with the rhizotomy, then patient's facet pain goes away. And that's what the RFA procedure is for. You think this one was better? Berndes? Hmm?
It's all about the number.
Think so?
Oh yeah, especially with this procedure.
I'm not arguing with you.
That medial branch is sensitive and you can get it blocked.
Yeah.
You might not have a reflexive musculature, that reaction there. That's what I'm thinking.
Well, I feel like I gave her more.
Yeah. Relax there, you're doing great.
Almost done.
You're doing really
Shot.
good. My friend, you're doing great.
Shot. I think I'm below the TP there, yeah. Can feel it. She's got really abnormal transverse process. And literally it's causing this thing to slide. So I want to make sure I get the nerve, the pain nerve, and then her muscles are contracting on top of it. And they're pushing my tip around. But I think we're okay. I think that did it.
I think it's better than the first one.
Shot?
I'm watching her.
Yeah, it looks good. All right. One more. You can see all the arthritis too. Definitely has an abnormal disc there. See the disc problem? Yep. So let's hope this works for her. Shot? That's too high. Shot? That's better. Shot? Can feel the TP there. Shot? It's too lateral. It's easy to get out of place. Too lateral. Shot. Too lateral. Shot. Inferior lateral. Shot. That's perfect. Right there. So let's inject some numbing medicine and hope this makes her feel better. So we're injecting a little numbing medicine because we don't want her to be uncomfortable during the burning phase. Shot. It's looking good. We're on track. Sometimes getting through the fascia is tough. There we go. Just about done. Too lateral. Shot. Better, but not quite where we need to be. Shot. That's getting closer. Again, it's a slippery TP. She has a very slippery TP. It's easy to slip off. But I feel like that's a good burn. All right, that's lateral. So let's just see where we are. Shot. It's like really nice actually right there. Just once again, there we go. Let's see where that is. Shot. That's really nice. If I can do that and a little bit lateral. Shot. Shot. Boy, just the slightest amount of movement really throws you off. Shot. 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 That looks really good right there. Shot. It's too medial. Shot. Shot. That's not bad right there. let's hope that does it. All right.
Lights on, please. Sitting on, please. Thank you. Thank you.
Let me try just one more, just before we finish it. I want to go a little bit more lateral on that TP, just to be sure. She's come so far, I just don't want her having anything residual. Shot. Everything okay?
Sorry, I'm squinting at the board.
Huh?
We're just trying to get some time.
Shot.
Trying to get the times on the board.
That should do it. All right, guys. Thanks, everybody. Good work. All done. I think she's going to be happy. Let's hope. All right. Henry, any questions?
Yes, we have a few.
All right, I'll come answer them face to face, all right?
Copy.
I'll be right there. So type up your questions for me, and I will do my best to answer them. Great job, everyone, today. Thank you. Hello, I'm Dr. Arjig Majan at the Duke Spine Institute, and I'm here with one of my patients who's just came in for a checkup today, and she had the Duke plasma rhizotomy. This is a new type of rhizotomy being done to treat facet joint pain. I say it a lot, but the most common cause of back pain and neck pain is a herniated disc. The second most common cause is a arthritic facet joint that's painful. And the standard treatment these days is something called a radiofrequency ablation, or RFA rhizotomy. The problem is that RFA rhizotomies don't deliver very much energy to the facet joint. So if they get the nerve, usually it's temporary and the nerve just grows back. We figured out a way to deliver more energy through what's called a plasma rhizotomy. It's a Duke plasma rhizotomy, and you had it done about a week ago. How do you feel today?
Amazing.
Yeah?
I have zero pain. So
And what did you say to me earlier? This is the first time you've been pain-free in
years.
How many years have you been dealing with back pain?
Yeah, probably 10.
10 years.
It's been a long time.
And
yes.
you look very happy.
I'm very happy.
Now,
very happy.
You did have the RFA. It worked for, gave you some relief for a little while, then the pain came back. And this feels different though.
This feels different, as in within 2 days I had zero pain.
It's awesome.
And now here I am a week later. I can run a marathon, I think.
Good.
I mean, I won't yet, but I can, so.
All right, and there's millions of people out there, and that's why we do these testimonials, really for them, not for me, not for you, but it's to spread the message of hope that there is a way to get out of back pain. You just have to stick with it, find the right place, get the right procedure, and eventually you can get there. And what do you say to that?
I say you're correct. That's Duke Spine Institute didn't give up on me. I've had several procedures, but you kept pursuing my pain until you figured it out. So thank you very much.
You're welcome. My pleasure. Anything else you want to say to your fans out there?
To my fans, come see this man. He is amazing. Duke Spine Institute staff is amazing. Everyone treats you with respect, and they listen to you. That's very important to me. So I just want to encourage people, don't live with the pain. Please come see Dr. Duke and Dr. Patel at the Duke Spine Institute.
I appreciate you saying that. The lesson here is don't give up on your pain.
Yes.
There is a way to fix it. And a lot of patients, probably about 25%, end up having more than one source of back pain. And we have to treat each source because each source requires a slightly different treatment. The rhizotomies definitely were what you needed, but you needed a rhizotomy that worked well because of all the inflammation of the facet joints and the scar tissue. And the plasma rhizotomy is the most powerful rhizotomy that can be done. It's only done at Duke Spine Institute. So congratulations on your new lease on your back. All right, let's get you out of here. This is Dr. Aru Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking.
Okay, great. Sorry we cut the testimonial short, but you can go onto our YouTube channel. We have hundreds and hundreds of testimonials just like that. Patients we've cured their pain, and feel free to watch it. So today we did a lot of surgery. We started out with a patient who came to us from Missouri with 3 herniated discs in his back. He's been suffering with back pain and left leg pain for years. When he left the surgery center after his surgery, about an hour afterwards, he had no more back pain and his leg pain was gone. The only thing he had was pain from the surgery where we cut into him, and that was it. And he said it wasn't too bad. Tomorrow I expect that surgery pain to be gone, and his pain he came here will be gone. Hopefully we'll get a nice testimonial out of him as well. And then the second patient we had today was from North Carolina. We didn't broadcast her because we did her an OR tube, and she was a thoracic facet rhizotomy with the Duke plasma rhizotomy procedure, which we just did here on this patient. And she's already gone, and she's very happy. And then our third case was a gentleman from California who had many back surgeries already, done it other places, and he was still in horrible pain after all that surgery he had done. He came here. I just talked to him before walking in here. His pain is 100% gone. And this is a father of a disabled child. He has to take care of that child. He's struggling. His mom's here with him. I feel so badly for him. He's just about my age, maybe a little bit younger, and he's trying to take care of a teenage disabled child that needs his full-time attention. And so he's been struggling with pain. He's traveled around trying to get relief, couldn't get it. Now the pain is 100% gone. We'll hear from him tomorrow as well. And finally, this last patient, she is from Indiana, and she and her husband are here because she's having 2 types of pain, thoracic pain and the lower back pain. When we were originally planning to do surgery, we were going to do surgery on her upper thoracic disc, but it wasn't causing pain when I examined her. So we changed the surgery plan yesterday, and we went ahead and agreed to treat the lower back pain from the T4-T5, which was, you could see it was very painful for her, and that pain will be gone now with the Duke laser disc repair. The upper thoracic pain, I did the Duke plasma rhizotomy, which hopefully it works for her. And basically during that procedure, what I'm doing is, if you look here at this model, you can see some nerves coming out of the foramen. They run over to the facet joint, and I went in and tried to burn those nerves, okay, at multiple locations along the junction where the transverse process meets the superior facet, right there. But in the thoracic spine, that TP is so narrow and pointy that when you put your probe on it to burn, it kind of slides up and down, so I had to position it just perfect. Hopefully it worked for her. Okay, we'll know. We've never had a failure, but hopefully it's working for her. All right, we're done with the surgery. Do we have any questions?
This first one comes from Bell on YouTube. They asked, I have a herniated disc on my C5 through C6. They have me on a lot of meds and wanting to do a fusion. Can I send my MRI?
Bell, 100% don't do a fusion. I know you don't want a metal plate in your neck. Once you fuse, all right, once you put a cage in there and a metal plate, you're losing the movement in your neck for the rest of your life. You'll have a stiff neck. plus it causes adjacent segment disease. Please send us your MRI. I'm 99% sure we can fix it with a laser.
Next question comes from Trust. These next two questions come from Trust. On YouTube, does Duke Spine Institute do MRIs also? I think that last question answered it.
Hi, Trust. Yes, Duke Spine does do MRIs. We have an MRI scanner here. Not everybody fits in our MRI scanner. It's a special kind of a compact MRI. So about 85% of people can fit in it. Some people, if you're really big shoulders, you may not be able to fit in it. So, but we do have our own MRI scanner here.
And his next question was, is a burning sensation under the shoulder blade a symptom of thoracic or cervical? My daily back pain is causing my face wrinkles. I'm going to need a facelift.
So Trust, is the pain behind the scapula, is it cervical or thoracic? To be honest with you, it could be either one. It's really hard to tell just based on that location. I would need to examine you, and I would have you do a few things. Number one, I'd have you turn your head towards the side that bothers you and see if you get a sharp pain. If you do, that's facet pain. So that would be important to know. And then I'd want to look at your MRI and see if you have any herniated disc in that area that could be causing that. Plus, it could be muscular, it could be rotator cuff. So I'd want to examine the shoulder, and I'd want to palpate some of the muscles to see if there's a sore spot. There's one particular muscle that can cause pain in that area that's really difficult to diagnose. It's called levator scapula tendonitis. Levator scapula tendonitis. Levator scapula scapula tendonitis. And it's literally a muscle that runs from up in your base of your skull area right down to the top corner of your scapula, top medial corner. And if you've got that, it hurts like heck. It could last for years. No surgery fixes it. It really requires a couple of shots and then you're done.
Next question comes from Tino, once more on YouTube, asking how many levels can be treated at one time with laser spine surgery?
So Tino's asking how many levels can be treated at one time with lasers, with the Duke laser disc repair. 6 levels in the lumbar, 4 levels in the cervical, and probably 4 levels in the thoracic.
And that is it.
Wonderful. Thanks for joining us. I hope you enjoyed today being with us at Duke Spine Institute as we live streamed all of our surgeries, and we took your questions during the surgery and after and answered them for you. So please join us next week. We have more surgery. If you know somebody who's suffering, send in your MRI scan through our free MRI review. It's a page on our website, dukespine.com. Feel free to fill out the form and get us your MRI one way or the other. Either mail it to us or upload a portal link with credentials or just upload the DICOM images. Great having you with us. Thank you, Henry, for doing such an amazing job. And hopefully we'll have some more great testimonies.